Welcome to the deep dive. So, you've shared your MSRA notes on hemophilia today.
That's right.
And our plan is to, well, really break down this genetic bleeding disorder, make the key info stick.
Exactly. A focused run-through for understanding and, importantly, recall.
We'll hit the definition, causes, risks, what's happening in the body, what else it might look like.
Diagnosis, management, prognosis, complications. The whole picture.
Perfect. Ready to dive in.
Let's do it. So hemophilia, at its core, it's a genetic disorder. It impairs the body's blood clotting process,
Right.
which means, prolonged bleeding, sometimes spontaneous bleeding. It boils down to specific clotting factors.
Okay.
Hemophilia A involves a lack of factor VIII, think A8,
A8, got it.
and hemophilia B, which is sometimes called Christmas disease, that's a lack of factor IX, so B9.
Okay, A8, B9. And what causes these factors to be missing or low?
It's genetic mutations, specifically in the genes that code for factor VIII or factor IX proteins.
A sort of typo in the genetic instructions.
Precisely. A glitch that stops those factors being made correctly or in sufficient amounts.
And who's more likely to inherit this?
Well, family history is definitely a key indicator if it's in the family.
Makes sense.
The risk goes up. And it predominantly affects males. This is because of its X-linked recessive inheritance pattern.
Ah, the X chromosome link.
Exactly. Males have XY chromosomes. If their single X has the faulty gene, they'll have hemophilia. Females are XX, so they usually need faults on both X chromosomes to be affected, which is much rarer. They're more often carriers.
Okay. So when these factors are low, what's actually going wrong during a bleed?
So imagine you get a cut. Normally there's this cascade, a chain reaction of clotting factors that forms a stable blood clot to plug the hole.
Right, hemostasis.
Correct. But in hemophilia, with factor VIII or IX deficient, that cascade gets interrupted. The clot doesn't form properly or it's too weak.
Leading to that prolonged bleeding.
Exactly. Impaired clot formation, poor hemostasis.
Now, could it be mistaken for anything else? Any key differentials?
Oh, definitely. The big one is von Willebrand disease. It's another common inherited bleeding disorder.
How's that different?
It involves a different protein von Willebrand factor. This factor helps platelets stick together, and it also acts like a chaperone for factor VIII. So, similar symptoms sometimes, but a different root cause.
Good distinction. And how common are we talking for hemophilia?
Globally, Haemophilia A and B affect roughly 1 in every 5,000 to 10,000 males.
Okay.
Here in the UK, estimates suggest around 6,000 people have some form of diagnosed bleeding disorder, including hemophilia.
Right. So what are the telltale signs? How does it actually present?
Well, there's a useful mnemonic, actually.
Yeah.
Be happy.
Oh, handy. Let's break that down. B.
B is for bruising easily, often one of the first things noticed.
Okay.
E for easy bleeding. So prolonged bleeding after minor injuries, surgery, dental work, or even frequent, hard-to-stop nosebleeds.
H is
For hematomas, those collections of blood in tissues like deep muscle bruises. A is arthrosis, or more specifically, hemarthrosis, bleeding into the joints. This is really characteristic, especially in knees, elbows, ankles. Causes pain, swelling.
That sounds significant. Next, P.
P for prolonged APTT. That's a specific finding on blood coagulation tests. The activated partial thromboplastin time is longer than normal.
Okay, APTT.
Yeah,
And
but
the
then-
second P.
This one's a bit more specific.
Right.
Potential for antibodies to develop against factor VIII treatment, particularly in hemophilia A. These are called inhibitors.
Right. Complicates treatment. And finally, Y.
Yeah, well, you might see these signs. It's just a reminder to look for this overall pattern.
B, E, happy.
Got it. So how do clinicians confirm it? What investigations are done?
The gold standard is a clotting factor assay. This directly measures the activity level of factor VIII or IX in the blood. Tells you if it's low and how low.
That gives the diagnosis and severity?
Yes, and genetic testing can then identify the specific mutation causing it, which can be useful for family planning and predicting inhibitor risk.
What about those routine blood tests? You'd see that prolonged APTT we mentioned. But typically, other tests like bleeding time, thrombin time, and prothrombin time, PT, will be normal.
Okay. And once it's diagnosed, how is hemophilia managed?
Management really revolves around replacement therapy, giving the patient concentrates of the clotting factor, their missing factor VIII or IX.
Is that given all the time?
It can be given on demand to treat an active bleed, but increasingly, especially for severe hemophilia, the standard is prophylactic treatment.
Prophylactic, meaning preventative.
Exactly. Regular infusions, maybe several times a week, to keep factor levels high enough to prevent most bleeds from starting. That's key for protecting joints.
Right. What's the general outlook, the prognosis, for someone with hemophilia now?
It's improved dramatically. With proper management, especially prophylaxis started early, people can live relatively normal, active lives. Life expectancy is near normal for many.
That's great progress.
It really is. Though severe cases can still face more challenges and need consistent, specialized care. Access to treatment is crucial.
Are there particular complications to be aware of?
Yes, definitely. Joint damage, chronic arthropathy, and arthritis is a major long-term issue from repeated hematorosis.
The joint bleeds again.
Yes.
Yeah.
It causes chronic pain, stiffness, reduced mobility,
Mm.
and, though rarer, intracranial hemorrhage bleeding inside the skull is a potentially life-threatening complication, particularly in severe hemophilia after trauma or sometimes spontaneously.
A serious risk. Okay, let's quickly recap. Hemophilia, genetic, X-linked, causes bleeding due to low factor VIII, or IXB.
Mostly affects males. Key features are easy bruising, prolonged bleeding, and those characteristic joint bleeds.
Diagnosis via factor assays showing low levels and a prolonged APTT on bloods.
And management hinges on replacing the missing factor, often prophylactically to prevent bleeds and joint damage.
Excellent summary. And for listeners wanting to dive deeper for MSRA revision,
Check out pastmsra.com and also freemsra.com for more resources.
great plugs. And just to leave you with something to think about, we've seen how vital these specific clotting factors are. It really makes you consider, doesn't it, what other seemingly minor genetic variations might have unexpectedly huge consequences for other critical biological systems.
Absolutely. A fascinating thought.
Thanks for joining us for this deep dive.